Ladies and gentlemen, please welcome to the stage Dr. Elisabeth Rosenthal and Dr. Khoi Lei.
Good morning, and welcome to the second day for the people who didn't want to hear Dave Barry talk about aging, or two young, beautiful people talk about the pleasure of sex in the British accent. You have clearly made the right choice here, okay? And with all due respect to Pulitzer Prize winners and MacArthur geniuses and renowned humorists and political columnists, actually, this is the most important book of the whole conference. And I speak honestly about this. So yesterday, Viet Thanh Nguyen was talking about the United States becoming this military-industrial complex, and we've heard that term before. But then, shortly afterwards, Dr. Topol gave a talk, and he pointed out that a few weeks ago, we became a medical-industrial complex, because now that is the dominant part of our economy. And we spend almost $1,000 per person in the United States per month on healthcare. Because, you know, $3.5 trillion, I can't put my mind around that number, but you say every single person in the country, and most of them are healthy, and we're spending almost $1,000 per person, and we're not getting the best results. There's something wrong. So, and even as a physician, I can't get my mind around all the complexities of this, and it's on the front pages every day. So until I was given Dr. Rosenthal's book, which really lays it all out. But before we get into that, I just want to introduce Dr. Elisabeth Rosenthal, or Libby, as I'm going to refer to today. Okay. So Libby was educated at Stanford, and then won a Marshall Scholarship, and read literature, at Cambridge.
Learned to write.
And got a master's, and then came back and attended Harvard Medical School, and then did her internship and residency at New York Cornell,
Right.
Which now is swallowed up by another conglomerate and named something else, right?
Right, New York Presbyterian, a sign of the times.
And then she morphed into an emergency room doctor part-time and a writer for the New York Times, because she's always been an underachiever, as you can see. And then went to China for a number of years, and in Europe as a foreign correspondent for the New York Times, and then came back, and her byline was to focus on healthcare issues. And currently she serves as the editor-in-chief for Kaiser Health News.
Right.
So, and it turns out that Libby and I were in medical school at the same time, just 1 year apart.
Yep.
So, and didn't realize that until we started comparing notes. But her book is amazing. It's called An American Sickness, and it kind of blends the approach of Malcolm Gladwell and Andrew Solomon of focusing on anecdotes and showing us the personal cost, and then zooming out and taking a wider angle and saying, well, why did this happen, and looking at the underpinnings of the medical system and the regulations that led to, in a way, this perversion of the costs. And she breaks it down in the first part of her book to all the different stakeholders. So there's the age of hospitals, age of insurers, age of doctors, age of medical devices, of pharmaceuticals, of medical education, of foundations, conglomerates, of third-party billers. So comprehensive. But Libby, how did you go from the physician to the watchdog role?
Well, I think it was a natural evolution. For me, it was a profession. My dad was a doctor. He was a pediatric oncologist. I became a doctor. And so it was a profession I cared deeply, deeply, deeply about. And what I'd seen as I evolved from ER doctor to journalist, which Khoi and I were talking last night, everyone says, wow, that's so weird, you know, going from an emergency room to being a physician. I feel like there's a natural evolution, because what drew me to medicine in a way was, of course, it was the family profession, but also because what I loved about it was hearing patients' stories and trying to help them, hearing their experiences, asking them questions, and putting it together into a narrative, in that case to make a diagnosis, what was wrong with them and how could I help them. For a journalist, the interviewing skill is kind of the same. So it's an interest, ultimately medicine is about an interest in people and doing the right thing for them. And that's what journalism is too. So, you know, as we mentioned, I had left medicine to be a journalist, not because I didn't love medicine, but ultimately in life one has to make choices. And I felt like I wanted to write about it more than I wanted to do it. And over time, in my years overseas where I wasn't covering healthcare, I was looking back at the US kind of with an outsider's eye and hearing about the costs going up, the difficulties people were having with accessing healthcare, from my mom, from my friends. And so when I came back to the US in 2007, I thought, wow, how did this get so expensive? I remembered when we trained, there were some, you know, I have a mild asthma, so I had a little inhaler that before I went overseas for 10 years, it was $10. It was cheap, and it was on patent still. I came back and
Albuterol, right?
Albuterol, yeah. I don't know how many of you use inhalers, but I came back by my calculation, it should have been off patent. I went into the pharmacy and lo and behold, it was still on patent and now it was close to $100. And I thought, wow, what is going on here? So I kept seeing these escalation of prices, which we had the ACA debate, which I think was really important, and it passed, which I thought was good because it gave people with pre-existing conditions some peace of mind. It was imperfect, and is imperfect, but it was a good start. But to me, the issue, which was then and is now, is we've got to control these costs because they've just spiraled. And unless we control the costs that we pay and the price that we pay, none of these ideas, single payer, market-based healthcare, nothing works. And more than that, so I wrote about that at the New York Times. I did a series called Pain Till It Hurts, which looked at the high costs of not these, you know, $1-million cancer treatments, but the ordinary stuff, because on whole, that's what drives this $3 billion, you know, trillion-dollar industry, trillion-dollar industry. It's all the little things added up, all the people who get vitamin D tests that they don't need, or echocardiograms every time they have surgery, even if they don't need it. So I wanted to look at these really basic things.
I thought we promised not to talk about echocardiograms.
Oh, yeah, well, you don't do this. I mean, that's my point. There are a lot of great doctors, such as this one, who would never do wasteful things. But P.S., when we looked at echocardiograms, we discovered, as you probably know, that at some places they cost $700, and at other places they cost $12,000. And by and large, insurers pay that and don't say, hey, what's the deal here? You know, same machine, same tech, why? And so in the end, after that series was done, I decided, a lot of patients had written in with their stories. I joked to my family that I became the repository for everyone who had a medical bill that they couldn't read in the US. I had stacks and stacks of stories and medical bills. And I decided to write this book using those stories, really in a way for myself, for my family, for my father, who would have been distressed by this, to understand, well, what happened? How did we get to this crazy high-cost place that none of us feel good about at this point? And what I found, which is what the book is, the first half of the book is about, is that it kind of rolled out slowly, and everyone wants a bad guy, right? We want to say, oh, it's pharma, or oh, it's, you know, these bad hospitals. And the truth is, there are really good people in every part of the system. There are really bad people in every part of the system. But the problem, and the reason it's the age of hospitals, the age of insurers, the age of doctors, you know, on and on and on, is because everyone together allowed this system to develop and was complicit in letting it develop this way. And that's the point of the second book. Once you understand that, we can all start taking it back and unraveling this crazy system, which from the outside, you know, you all must have friends from other countries who go, why do you guys put up with this? You know, why $125,000 for a hip replacement? What's that about?
It's I think there was a study published at Harvard in 2005 that was really shocking to me because in the study, what they did is they looked at everybody in the United States who went bankrupt. Okay, and when you look at that, and not surprisingly, about over half say that the main event that drove them to be bankrupt was medical bills. Okay, so kind of you let that sit for a second and say, okay, well maybe that makes sense. You get really sick and you lose your job and then you've got all these bills. But it turned out, and this is why we need health insurance for more people.
Yeah.
It turned out 3/4 of these people who went bankrupt because of medical bills had insurance.
Right.
So let that sink in for a minute. 3/4 of people who go bankrupt because of medical bills were insured. So I think one of the provisions you talked about in the Affordable Care Act was a really important thing in 2016 where they said you have to cap the amount of money that you spend on medical bills in 1 year, right? That the insurers would have to just not say that you could just pay an unlimited amount because things are out of network or whatever.
Right. Well, this is in terms of the insurers you're talking
Yeah.
about. Okay. Yeah, no, I think this is an important, and this is a nice example of, we think we're doing something helpful to control costs. And because, the thing that impressed me after writing this book is the business of medicine is so agile and flexible that every attempt to control it yields the opposite. So what happened in this case was the Affordable Care Act smartly discovered that some insurance companies were only spending 60% of premiums on patient care, right? That's not very admirable, right?
That's called the loss ratio or something like that?
Yeah, it's called medical loss ratio. So they thought, aha, how can we make that better? Okay, we're going to say to all these insurers, you have to spend 85% of your premiums on medical care. And you can do, your advertising, bonuses, whatever, with that 15%. And they didn't think much further than that because they thought, well, sure, that should solve the problem. Well, guess what? When you ask, well, why are they willing to pay it? I talked about it yesterday. I had a screening colonoscopy that a hospital billed $12,000 for, and my insurance paid it. And I'm thinking, why would they pay that? Well, think about it, right? They're allowed to keep 85% of my premiums.
15, right?
Right.